Hello, my name is Tom Stinchcombe. I'm a medical oncologist who specializes in thoracic oncology. I work at Duke Cancer Institute in Durham, North Carolina. And thank you for having me today. RET fusions represent about 1% of patients with non-small cell lung cancer with adenocarcinoma. So this is a relatively rare molecular alteration, but it's very clinically important because there are new therapies available that target this specific subgroup of patients. Celepractinib, which is also known as LOXO-292, when it had a number, is one of the agents available. The other one is pralasetinib, which was known as BLU-667. The two agents were, I'll start with the celepractinib. It was studied in patients who had prior platinum-based therapy, as well as treatment-naive patients. Among the patients that had prior platinum-based therapy, the response rate was around 60 to 65%. Among the treatment-naive patients, it was around 85%. Importantly, also, this drug demonstrated the ability to have CNS responses. So patients with brain metastasis who got the drug did have a notable shrinkage. The CNS response rate was 90%. Now, I think with this drug, since the response rate is higher in the treatment-naive patients, and building upon our premise that if you have an actionable alteration, you should get the targeted therapy first, I would recommend that they get this agent first. I think a big component of this is that the duration of response was very long. Also, the drug is well tolerated. The main side effects can be some hypertension, some increased liver tests, and so it's overall better tolerated than chemotherapy and immunotherapy. Another drug, pralasetinib, was also studied in the same sort of treatment group. Response rate among patients who had prior platinum-based therapy was around 60%. Among treatment-naive, it's around 70%. And this was well tolerated, with most common AEs being hypertension, as well as some anemia and some neutropenia. So I think that both these drugs are more active than chemotherapy and immunotherapy, and better tolerated, so that they would be the preferred option for patients who have a RET fusion. And most of the time we test for this on our broad-based NGS panel testing, whether it be by liquid biopsy or ctDNA, as it's commonly known as, or the traditional tumor NGS testing.